and it's usually then converted to, or leads to the synthesis of leukotrienes via the lipoxygenase enzyme pathway. Again, leukotrienes are involved in the inflammatory process, or it will enter the COX pathway, COX-1 or COX-2, and lead to the generation of prostaglandins. And prostaglandins are quite important in stimulating pain. So, which is why we see a lot of pain in OA. It's due to that generation increases in prostaglandins and also in bradykinins, which activate the pain receptors. So when we have prostaglandins and also bradykinin due to that inflammation, so here we can just really have some underlying inflammation, causes increases, sensitizes nociceptors. And again, increase in the sensitization of nociceptors will cause them to depolarize and fire. And obviously their firing is how we sense pain. So then this then leads to pain sensation being sent to the brain. And obviously this happens due to the peripheral nerves. Which are based on the A alpha fibers, or the A beta, A delta, I hate writing D, or the C fibers. Obviously these ones are myelinated, and C is unmyelinated, and therefore C will usually transmit chronic pain together with delta. Although delta is myelinated, it's small and it's involved in slower transmission of pain. And in terms of pain transmitting, so it all begins in the peripheral nerves, which then so these will be the fibers, either the A or the C. So they will enter they'll go into the spinal cord, basically. So they transmit directly into the dorsal horn of the spinal cord. So this is the spinal cord, and this is the dorsal horn of the spinal cord, where they will synapse with other interneurons, and obviously there are neurotransmitters there. So they will synapse with other neurotransmitters, and eventually that signal travels on the ipsilateral side to the pain receptors in the brain, which are usually in the thalamus. So really we'll have entry into the medulla until you reach the cerebral cortex. So really, and then that pain is experienced. Shall we write it in red, because obviously this is pain and it's painful. So pain is experienced once that message reaches the brain. And as pain is experienced, if we were to remember that, prostaglandins, due to the cytokines that are being, another cytokines that are constantly being expressed due to this active process there that's undergoing. So we'll have a lot of prostaglandins available, we'll have a lot of bradykinin available, we'll have a lot of cytokines available. So this process there, the activation of C fibers particularly, is constant, and it occurs, because even the modulation that happens there is based on trying to find a balance between the sensation that is being received. So if that pain sensation is constantly, I'm just going to check see if I've got time. I think I have 20 minutes remaining. So if there is constant pain ongoing, the C fibers are constantly firing, and this modulation will allow the pain sensations to reach the brain. So in terms of treating the management that occurs with OA, it has to be either physiotherapy and exercise to increase the range of motion of that joint. And again, with management, patient education is important. So we need a lot of patient education to teach the patient about the disease and how to manage it. Because if we were to remember, pain has a lot of psychological factors as well, and emotional factors as well. So there will be the fear of disability as well, the permanent loss of joint. So education will really help in terms of managing and modulating pain as well. And then the non-pharmacological aspects again will include things like footwear, and perhaps using crutches if it's a knee, and other joint supporters, braces, just to protect the joint. We can then use analgesics, things like the COX inhibitors, paracetamol, short-term ibuprofen, non-steroidal anti-inflammatories. Steroid injections can be used just as a short-term basis, and if all fails, again in terms of analgesics, morphine can be used in people who are not indicated to have surgery. But the final aspect of care is surgery, where you can have total replacement of the joint or joint realignment. So it can be total replacement of that joint, or a joint realignment, or indeed defibrating that joint to remove osteophytes and any other fragments that are in there. So clinically, what people will present with when they have OA is a lot of pain and disability, limited range of movement, crepitus, loss of range of motion, and there can be a little bit of sign of edema, inflammation, and there will be some edema. But it's important to remember that OA is not an inflammatory joint disease. It's more of a degenerative disease. But in that degeneration, when that loss of balance occurs in terms of regenerating cartilage and regenerating bone, inflammation does become triggered. And when inflammation is triggered, then you will have that underlying secondary inflammation causing an increase in prostaglandins, in bradykinin, which then cause an increase in sensitization of nociceptors and other inflammatory cytokines as well. Will also activate nociceptors and cause them to fire into the spinal cord and eventually into the brain where pain is sensed. And it's usually mostly the C fibers which are myelinated, which transmit pain to the spinal cord, and also the A delta fibers as well, which are myelinated but smaller. Again, with pain, we must remember that pain is one of the most disabling conditions. So there is a lot of socio-economic impact based from osteoarthritis. And when I say socio-economic, I also mean, that people will reduce their activity, stop going out, and particularly pain in OA is usually seen after resting, after that joint has not been moved, but or even pain at night after a lot of use of that joint. So people will stop using the joint to try and limit the sensation of pain. People will feel disabled because they can't use that joint. So if someone is still working, perhaps, or even, just doing some work at home, perhaps they are on, gardening, they may have to have a gardener come and do that for them. Driving as well, again, you lose that sense of freedom and mobility. Say if it's in the finger, you can't really use your joints properly, because the joints that are usually affected are the fingers, the wrists, the shoulder, the hip, and the knee, and again the ankles and the toes. The elbows don't get OA that much, so I forgot about that. But then if you can imagine, if it's in the knee, you can't really walk. If it's in the hip as well, walking is affected. If it's in the hand, you can't really do anything with your hands. Even eating becomes a problem. So it's important to manage that pain and also manage the psychological impact and effects of the disease, just to help, because sometimes the pathogenesis might not be pronounced, might not be causing as much disability, but pain and the psychological impact of that pain could be the disabling factor. So managing the underlying pain and indeed treating the clinical symptoms and the clinical presentation, what the patient actually presents with, is what's more important than just looking at the radiological features and saying, oh yeah, you need a joint replacement, or it's because obviously the radiological features will continue to be there and they might even worsen. So really there's not much to be gained from just treating radiology. It's more important to treat the clinical features and to educate the patient about the symptoms that they are experiencing and the etiology of the disease and what to expect in the future. And also really to emphasize that, exercising, physiotherapy, using that joint will not damage it any further, but will help the muscles to stabilize the joint and will increase that range of movement so that they do not become disabled. So the treatment that's used will be simple analgesia like paracetamol, cocodamol, steroids. If there is too much inflammation, perhaps a one-off injection might reduce that inflammatory process to again manage the pain. But obviously paracetamols and ibuprofen, they work on COX. And again, if one is giving inflammatory NSAIDs, it's important as well to think about protecting the the GI system by giving antacids. And I think that I'll end it there in terms of OA. So in the next session, I'll look at inflammatory arthropathies, including rheumatoid arthritis. And again, we'll look at, it's because it's mostly inflammation. So the inflammatory process will be mostly based on the pathogenesis of the disease, whereas the inflammatory process in OA is mostly based on the underlying cause of that chronic pain that is experienced in OA. So yeah, I'll end it here for today. Thank you. And then in the next session, I'll just look at RA. And it's important as well to say that osteoarthritis does not have any markers. So even doing bloods, it will be negative for things like rheumatoid factors. It will be negative for inflammatory factors, even though there is a secondary underlying inflammation. It will be negative for inflammatory markers. So the most important marker is the radiology and the clinical symptoms that are presented.